Hi, good afternoon, APAACI participant. So welcome to the plenary session 2 under the topic of the advance in allergen immunotherapy and the future of digital health. It's my pleasure to introduce my co-chair lady, Professor Mauricia Recto, that she is the well-known professor in allergy from Philippines. So just a bit of information that we have a minor change of the schedule. We will start from Professor Canonica and we will follow by Professor Sean Buski. And after the Professor Buski, we will take all of your Q&A, and you can feel free to put your question in your chat box after the below the screen. So and then we will play the video clip of Professor Oliver Farr after Professor Sean Buski. So I would like to ask my co-chair lady, Professor Recto, to introduce the first speaker. Please, Professor Recto.
Thank you very much, Professor Tantilipicorn. And it is my pleasure indeed to introduce our first speaker, who will speak on AIT, or Allergen Immunotherapy, as a prototype of personalized and precision medicine. He's a well-known speaker. He's an expert in personalized medicine, and he belongs as the head of personalized medicine in asthma and allergy clinic at the Humanitas Hospital or University in Italy. And he has held several prestigious positions as ex-WOW president, and is the board member of the ARIA, Galen, and GINA guidelines. So it's my pleasure to introduce Professor Giorgio Walter Canonica. Professor.
Thank you very much, Mauricio, and thank also to Pongsakorn. And it's really a great pleasure for me to talk about this topic with my Asian colleagues. Well, my task today is actually to talk about the allergen immunotherapy as a prototype of personalized precision medicine. I mean, first of all, my disclosure of interests, of course, but actually I have a major disclosure of interest. I love allergen immunotherapy. Let me go first to a very short state of the art. With my friend and colleague Oliver Farr, we published recently about looking at the future, of course. But what was the situation about allergen immunotherapy? Well, starting more than 1 century ago, actually we had different routes of administration and a lot of double-blind placebo-controlled trials, and as depicted in this figure, we really stressed the double-blind placebo-controlled trials for each of the routes of administration. But if you look at PubMed, a few days ago I checked, wow, we have a lot of papers. Of course, I had to make a selection about that. And what is interesting is that the literature is going up in terms of numbers. And I wish to stress, as far as allergic asthma, in real world, and we'll come back later about that, the real world evidence, well, we had data concerning the reduction of inhaled corticosteroids in asthma, and also, as reported here, in terms of exacerbation, well, in other words, asthma attacks. So this was the conclusion of this paper. On the other side, as far as mild to moderate asthma, we have data coming from Japan that's showing once again that as far as seasonal asthma exacerbation, we have a significant reduction using, of course, sublingual immunotherapy. As far as allergen immunotherapy is concerned, as I published a few years ago, if you look at the systematic reviews and the meta-analysis, invariably, IT is effective as far as rhinitis and asthma is concerned. But I wish to stress with this paper that was very recently published, once again, is a systematic review and meta-analysis in allergic rhinitis, talking about the different treatment. I'm talking about steroids or antihistamines. But as far as allergen immunotherapy is concerned, I think that it's important. The data that is looking at the minimal significant clinical difference. And this was the case. In other words, the quality of life improvement that is possibly related to these disease-modifying effects for the authors is, in my mind, very important. Now let me switch to the precision medicine. With some friends, including my dear friend Jean Bousquet, we published a few years ago allergen immunotherapy as a prototype of precision medicine. So let me go back to this paper in the New England, where the claim was that precision, personalized, often are used interchangeably. This shouldn't be the case. Why? Because when we are talking about precision medicine, we are talking about the endotype. In other words, we are focusing on the mechanism of the disease. Let me show you something that is the case. First, we have to identify the mechanism in that is the patient's disease. Then, with a specific diagnostic tool that is able to identify the mechanism, then we have to develop the treatment that is able to block the mechanism. Now, looking at the left, this is what I just described. But if you look, what about allergen immunotherapy? Do we know the mechanism? Yes, of course. Do we have the diagnostic tool? Yes, of course. And we also have the treatment that is able to block the mechanism. Well, actually, we have really to make an autocriticism. Why? Because this was there since a long time. But unfortunately, we didn't think about to propose it as precision therapy. We were mainly focused in the beginning on a mass target therapy, that selecting till the allergen immunotherapy as, based on a very precise, and we will come back on that, diagnosis. We can talk about personalized medicine. And what about the personalized medicine? Well, this means that we have to focus on the patient, on the person, and not just on the mechanism. Let me just give you an example. If the first step when we are treating asthma is to choose the proper device. In Italy, on the market, we have 58 different devices. We have to choose the proper one. Why? Because my friend Christian Virchow published that if you are just giving the written instruction, just 20% of the patients are able to use properly the device, and you can reach 50% if you are instructing the patient. And you can confuse him even more with multiple inhalers. So let's go to the personalized medicine and allergen immunotherapy guidelines. This is the one that was published by APAACI 2 years ago. And to reach a correct prescription of immunotherapy, in the beginning, you have to start with a component-resolved diagnosis. Is this important? Definitely, yes. Why? Because the success of the immunotherapy is largely dependent of the proper selection of patients, and in other words, on the correct diagnosis. In that I mean PANDA, which means the allergy molecular diagnosis. And once again, very recently, we published a paper that is concerning allergen immunotherapy as still a unique and unmatched model of personalized medicine. In that, I mean, once again, that molecular allergy diagnosis is really in the beginning of the algorithm to reach the prescription of allergen immunotherapy, and is considered one of the validated tools to prescribe properly allergen immunotherapy. And this is the way for having a correct diagnosis for allergen immunotherapy as precision medicine in the context of personalized medicine that is really empowering the role of allergist. Why? Because he is able to choose the proper route of administration, the different preparation, the personalization, and all the other stories for the best of our patients. It's time to change so. Why? Look at the guidelines. This is a guideline that impressed me, published in JAMA by our American colleagues, and they use the grade methods to make the recommendations. And look, of course, as far as asthma is concerned, the recommendation is not to use it, immunotherapy in severe persistent asthma. Whereas when asthma is under control, of course, the use of the immunotherapy is supported and recommended. But, okay, let's go to this point. Sublingual immunotherapy is not recommended with a conditional recommendation. And, you know, this is not the case for subcutaneous. That is recommended, but with the same condition and the same grading system. Well, this is a little bit confusing me. Whereas if approaching with the grade system again, but in the APAACI guidelines for house asthmatic immunotherapy, you have for subcutaneous immunotherapy recommendation for children and adults. For drops, you have recommendation that is for children, not yet for adults. For tablets, you have recommendation for both children and adults. And as far as asthma is concerned, of course, when asthma is controlled, allergen immunotherapy can be prescribed, and then we can discuss, and this is for the discussion, when asthma is first, controlled or partially controlled. Personally speaking, I would say, first of all, we have to control the asthma, then we can go ahead also adding immunotherapy. Nonetheless, let's stick with GINA. And in GINA, the prescription of sublingual immunotherapy as other controller therapy is accepted. What is a step forward to improve personalization? Of course, phenotyping the patients. And this is, I just put this one to show what phenotyping means, for example, in asthma. And in asthma, we know that allergic asthma, eosinophilic, non-allergic asthma, or neutrophilic asthma, they have a different way that is possible to target different biologic treatment. But I love the definition that was given by Joanna Gace and Mo Shami. Well, that in the future perspective, we should go to the patient teratype, not anymore phenotype or endotype, but teratype. In that, I mean that we should have a precise diagnosis. In this case, I would say the sensitization profile using up to now the molecular allergy diagnosis to prescribe properly the allergen immunotherapy, and if the case, also a biological treatment. And if we are talking about biomarkers, biomarkers are becoming more and more important, and we very recently published with our Australian colleagues that there is something that is coming now, and is the specific IgG2 that are able to identify the high responder to allergen immunotherapy. And this is a step forward to select the different patients. And once again, the molecular characterization of the sensitization is helping us for the optimal selection of responder to a target treatment such as allergen immunotherapy. Of course, the omics science will help us in finding some new biomarkers, and of course, I'm talking about genomics, metabolomics, proteomics, but we shouldn't forget humanomics and personomics, because we are talking about personalization of the treatment. And if we go to the world, and this is a paper by Jean Bousquet, I wish to stress one point, that when we are talking about the algorithm for prescribing allergen immunotherapy, well, in the beginning of the story, once more, there is the component resolved diagnosis, which is one step that is going to precision medicine. And I'm pleased to share with you this data. Why? Because this paper was having Tom Casale, so I mean also, and not just him, but also Andrew Liu, about the US, because also the US are nowadays considering that the component directed allergen immunotherapy is really a step forward for having good results. As probably you know, we published the consensus document, the first consensus document on molecular based allergy diagnostic almost 10 years ago, where we say that it is important to distinguish the genuine sensitization and to identify the primary sensitizing allergy. In other words, that this approach was able to change the clinical practice. And in fact, I mean, the data are that using this kind of approach, you have to change up to 50% of the prescriptions that you could do using just the skill prick tests. And PAMDA, that is Precision Allergy Molecular Diagnostic Application, was supporting it last year when we published the update of the document. And this is even more important when we are talking about the new approaches. And in that, I mean the use of monoclonal antibodies to the different allergens, or better, the different components, or the different major allergens, as recently reported in the Journal of Allergy Clinical Immunology by Philippe Gewart. And in addition, as my team published recently, it's important to evaluate how to integrate the use of allergen immunotherapy and the biologics. But even in this case, it's very important that this kind of combination that might be useful as far as effectiveness or adverse event, or steroid sparing, you know, to use a diagnosis that is very personalized. How to create a sustainable new scenario to reflect a change? Well, I think that real world evidence and personalized medicine is very important. Why? Let me just give you a brief example. As far as asthma is concerned, the selection of the patients for randomized controlled trial makes the story very easy. That then you can enroll a little bit more than 1% of the real asthmatic population, you know. And just an example, 10 years ago or so, females were not enrolled properly in the trials. and this is very recent, as far as obese people, and these are all the trials with the biologics, are not considered for the selection in the trials. And also the Afro-American people are not enrolled in those trials. So, I mean, are not represented, but in clinical practice. We have to consider both obese people and the Afro-Americans. So in other words, so when we are talking about efficacy and effectiveness, we are talking about two different things. And for instance, adherence is a variable that is very, very important. That's the reason why we published a manifesto as far as real-life research is concerned. And also the regulatory authorities nowadays are opening the door to the evaluation of the real-world evidence, and I'm talking about FDA and here EMA. We published a position paper this year with the European Academy of Allergen Clinical Immunology on allergen immunotherapy and how to evaluate the real-world evidence. And as you can see, actually the new proposal about the evidence are stressing one point, and I'm talking about the registries. The registry of real-world evidences as one of the best way to collect properly data. And these concluded with a call to action. And the call to action was to establish more allergen immunotherapy registries to get real-world data. And that's the reason why the Italian Society set up the Italian Registry of Allergen Immunotherapy, and the British Society did too. So my key message nowadays is that the big data that are coming from the Registry of Allergen Immunotherapy will provide really great insights about the molecular components, the allergen immunotherapy effectiveness, the eligibility to allergen immunotherapy in the best personalized way is possible. With this, I conclude. I thank all my co-workers. I thank you all for your attention. And here is my mail if you wish to contact me. Thank you very, very much for your time.
I think I will start with because you say that the two aspect between the real world evidence and the RCT, and you talk about the precision medicine and the component resolved diagnosis. Would you mind to elaborate more about which one on which scenario that you would use the biomarker to determine the real world evidence? This is the responder or non-responder.
Well, I think I'm convinced, and I'm sure that my friend Jean Bousquet will help us how to collect properly this data and also how to analyze these big data. Because, for instance, with the experience that we have with the severe asthma registries, is nowadays clear how combining properly with artificial intelligence or machine learning system, we can really get some information that you will never get with the randomized control trial. Let me just making a simple example. With the severe asthma registries, we find out that actually 42% of patients, they have nasal polyposis, and 25% they have bronchiectasis. I must confess that a few years ago, I never explored with the proper imaging, these aspects in my severe asthma patients. The same, I would say, with the proper diagnosis using molecular allergy diagnosis. For instance, we can, in this case, retrospectively, having this data, to look at, for instance, if the presence of positivity for some components. Let's think about the P23 in might asthma patients. Well, if this kind of positivity is related or not to a successful allergen immunotherapy. I think that from these big data, we can really have a step forward.
Thank you very much, Professor Canonica. And I think it's 2 minutes before 10, and think we thank you very much for contributing and then speaking in the APAACI. So that will lead into. Thank you very much, Professor Canonica.
Thank you all.
And thank you very much, Professor.
And we lead to our next speaker that after Professor Canonica talking about the big data and the integration about the real world evidence. It's my honor to introduce the world-renowned professor in allergy from Montpellier. I think I can say that he needs no introduction, but at least more than 1,000 publication, the lead author in the area and the GINA guidelines. So Professor Bousquet will talk about the mHealth and the artificial intelligence and the future of the allergy management. Please, Professor Bousquet.
Thank you. Well, ladies and gentlemen, I would like to discuss with you today, where are we coming from? Sorry, I have a problem with my... Okay, it's coming. Okay. Where are we coming from? Sorry, I need to put this here, otherwise I won't see anything. Where are we going? This is a painting of Paul Gauguin, but I think it is quite interesting. And what I would like to say, first of all, these are my conflicts of interest. Well, first of all, how do we understand allergic disease integration, integrating classical, disruptive, and innovative methods? Secondly, from mHealth phenotypes and genetic tools to the translation to management and policies. I will not touch the two last issues, but I would like to tell you that we have now new tools which are not based on genomics, but that may be quite powerful. What is digital health? It's a broad umbrella encompassing e-health with big data, genomics, and artificial intelligence. So today, I'm going to discuss digital health and how in our group we use this for 20 years. So we started from clinical observations to make a hypothesis. Well, it was in 1990 and I saw a lady with severe asthma. I gave inhaled steroids. 1 month later, she came. FEV1 went from 50% to 100%. I was very satisfied, but she was not because she had rhinitis. From this, we did epidemiologic studies and we found that perennial rhinitis is an independent risk factor for asthma in non-atopic subjects. We also did many biologic studies and we found the same inflammatory component in the nose and the lower airways in asthmatic patients. So this led to rhinitis and asthma intertwined, and the one airway, one disease concept was proposed earlier by Estelle Simons. And this led to ARIA. But although 90% of asthmatic patients suffer from rhinitis, suggesting common pathways, only 20 to 30% rhinitis patients have asthma, suggesting rhinitis-specific pathways. So the concept, one airway, one disease, is an oversimplification of the clinical evidence. And this is what I want to discuss with you today. So from this clinical observation, we will refine the hypothesis using big data and MEDAL. Well, MEDAL was an EU project, Mechanisms of the Development of Allergy, and it was an integrated approach from phenotypes to system medicine. 2 questions. What MEDAL will bring to the clinical practice of allergy for novel care pathways? What MEDAL will bring to the knowledge of allergy for prevention? Well, MEDAL is combining 14 birth cohorts with 44,000 children at birth, 22,000 at 4 years, 20,000 at 8 years, and now we have over 18,000 at 20 years. We have also 18,000 children after puberty, and we have used the harmonized questionnaire of almost 400 questions. Then we had 4,000 IG with a microarray, which was better than the classical system, 23,000 GWAS, 9,000 epigenetics, 2,000 proteomics, 1,000 transcriptomics, and 10,000 children who have studied with air pollution data for 10 years. The major message of MEDAL is that comorbidity between eczema, rhinitis, and asthma is not associated to IgE or is little associated to IgE. So there should be genes of multimorbidity and genes of IgE sensitization. And this was, I think, the major message. This was confirmed by data-driven studies. So we had, on one hand, classical phenotypes using hypothesis-driven phenotypes and novel data phenotypes with data-driven. I'm not going to discuss the 50 papers of MEDAL, but one which is of great interest as well. You know that at puberty, there is a gender switch between men or boys and girls. But this gender switch only occurs in multimorbidity. It does not occur in rhinitis or asthma alone. So we think that there is a different disease between multimorbid rhinitis, asthma, and single disease, asthma and rhinitis. Refining the hypothesis 2, we went to mHealth. Well, the problem is the following. With a cohort, you have 44,000 children. With mHealth, you can have many, many people and many more data. So we use a very simple tool in 30 countries. It is just a visual analog scale, like in pain. Is it not at all bothersome or extreme or bothersome? And we have only 4 questions. Overall, how much are your allergic symptoms bothering you today? Your nose symptoms, your eye symptoms, and asthma. We also have all medication lists and now immunotherapy lists for all countries, which is customized every year. I'm going to show you some data. This was the first study we did. It was in 2017. And what we proposed was to cluster visual analog scale nose with visual analog scale asthma. 32,000 days, Spearman rank correlation 0.50, not very good. But if you assess 4 phenotypes, in blue, no asthma, no rhinitis, perfect. In orange, eye asthma, low rhinitis, very, very few people. The concept of ARIA. In green, rhinitis without asthma, and in red, rhinitis and asthma. And you see that green and red are totally different. In one, you have a reduction. In the other one, you have an increase. So if you go to conjunctivitis, it's exactly the same. And we think that there are new phenotypes. Well, if you have rhinitis with a VIS over 100, which is a high severe rhinitis, you see that VS work is 40. You have rhinitis and conjunctivitis, it is 50. Rhinitis and asthma, 52. And rhinitis, conjunctivitis, and asthma, 60. So we think that there is a different phenotype here. Now, if you look to the severity of symptoms, each symptom for nose, eye, and asthma is higher when you have the 3 diseases, suggesting, first of all, that rhinitis and rhinoconjunctivitis differ, and that there is an extreme allergy phenotype associated with a number of diseases. However, mHealth is only hypothesis generated, and you need to go back to canonical epidemiology to confirm what is done. Well, I must say that Giovanni Viaggi and Fabio Cibella were clever enough to differentiate rhinitis and rhinoconjunctivitis before we did it. However, went further. This paper should probably be in the Guinness Book. Why? Because using the same data in the same patients, in the same journal, a first paper was published in 2018, and the same month, this paper was accepted. The only difference was that we added conjunctivitis. And you can see here, in the whole population, that when you have conjunctivitis alone, rhinitis and conjunctivitis, or rhinitis, conjunctivitis, and asthma, you have a totally different pattern. And this is both without asthma and with asthma. So conjunctivitis is present when there is an increased number of allergens. And we have done many other studies, but one of them is quite interesting because it is a study in the Portuguese National Epidemiologic Study. If you assess severity of eye symptoms, you will see that nasal symptoms with impairment are present when conjunctivitis is 80% there, without impairment 40%. So nasal symptoms are associated with the presence of conjunctivitis. And more importantly, if you assess severe asthma using LCA and CART, which are statistical methods for that, in this case, the first symptom to be considered is ocular symptom. And no one in asthma has done that clearly. However, if using mask, our system, IT system, you can see that in this severe asthmatic patient, VSI, VS nose, VS asthma, and VS dyspnea are always or mostly coming at the same time, indicating that conjunctivitis is possibly understood in asthma. The fourth hypothesis is that, well, from big data to mHealth to canonical epidemiology, now to genomic hypothesis. So we published a paper, Are allergic multimorbidities and IgE polysensitization associated with the persistence or reoccurrence of fetal type 2 signaling? Why fetal type 2 signaling? Because, first of all, the embryology of the respiratory tract is different. The lungs are coming from the endoderm, the nose, the mouth, and the eye are coming from the ectoderm. So we may think that there are mesodermal responses, ectodermal responses, and endodermal responses. The mesoderm is associated with T2 response, IgE and T2 inflammation. And it is possible, at that time we felt it was possible, that multimorbidities were associated with mesoderm. The endoderm, it's asthma, and it induces a non-fibrotic remodeling. It's also gastroesophageal. Ectoderm is the nose and the skin, and there is minimal remodeling. So when you're considering diseases, you need to consider the mesoderm, the endoderm, and the ectoderm. This is a study of MEDAL. We did transcriptomics in 785 subjects. As you can see here, there is multimorbidity. You have plenty of red. If rhinitis is a single disease, you have plenty of black. And there is not a single gene overlapping between multimorbidity and rhinitis. There was no gene associated to asthma as a single disease or atopic dermatitis as a single disease. What are these genes? These genes are IL-33 and IL-5, eosinophils, and polysensitization. We also confirmed this in another cohort, the Puerto Rico cohort, with gene sequencing. And the correlation was 83%. 83%. It's extraordinary that two cohorts using two methods are coming with the same gene association. On the other hand, the black is toll-like receptors. So we have on one hand IL-5 and IL-33, on the other hand, toll-like receptors. This is why rhinitis is polysensitized when it is alone. It is polysensitized when it is with with asthma. And we propose this graph, which is rhinitis alone is TLR, rhinitis, asthma, and polysensitization, it is IL-33 and IL-5. So, from a hypothesis of one airway disease, we're arriving to a genomic hypothesis that there are two diseases, in fact, rhinitis alone and rhinitis, asthma, and polysensitization. Now, back to canonical epidemiology. There are plenty of studies, and I'm not going to show you very recent data where this week we are repeating them to check on a general population cohort. So is this hypothesis plausible? Rhinitis alone starts later than rhinitis and asthma. HLA association is aberrant. I'm not going to show you this. Eosinophil levels differ in rhinitis and asthma, and there is a transition from rhinitis to rhinitis and asthma only in polysensitized patients, or mostly in polysensitized patients. Well, this is a study called the EGA study. It is in patients. And what you see, age of onset, allergic rhinitis, 33 years. Allergic rhinitis in asthma, 14 years. Hypothesis confirmed. Number of allergens from 6.62, because we had a big, to 15.22. Ig levels from 79 to 1.66. Eczema, 35%, 52%. Conjunctivitis, 46%, 55%. Moderate to severe allergic rhinitis from 16 to 27%. And eosinophils from 191 to 253. So at the end of the day, ladies and gentlemen, we found that the phenotypes that we identified by different methods, confirming them by genomic analysis, are also confirmed using back-to data. So what we think is the following. At birth, the high Th2 of the T2 response is decreasing completely, except in the 4% of patients with the atopic march. If you have some early sensitization, like birch pollen, 2 months after birth, then you have an early sensitization, but it is monospecific. Then you have preschool children multimorbidity and polysensitization, children multimorbidity and polysensitization, and then you go to something different, children's rhinitis, mostly monosensitized, which is in post-puberty monosensitization, and adult multimorbidity, because possibly the reoccurrence of Staph aureus. So you can distinguish multimorbidity and polysensitization leading to asthma and rhinitis from rhinitis alone with a monosensitization or polysensitization. And in fact, there is something which is very important. Viruses can make reoccurrence of T2 signaling. Staph aureus and diesel exhaust can do it. So, ladies and gentlemen, I think that I've shown you that there is something else in rhinitis. Thank you.
Thank you very much, Professor. That was really a thought-provoking presentation. And I'm sure we have a lot of questions to ask Professor Pongsakorn about this topic. So may I ask the first question? Professor Bosquet, with all you've gone through with the digital methods of monitoring allergic rhinitis and even asthma, it's really remarkable that you could come up with all these theories and also this data that is very important for us to understand allergic rhinitis better. I was just wondering if this type of phenotype that you have been presenting, the difference between allergic rhinitis and allergic rhinitis with conjunctivitis and asthma, if they would have, it could predict a poor response to immunotherapy, or maybe that could be a poor response to monoclonal antibodies because it is a different phenotype?
This is a very clever question. Thank you. Well, we don't have the data. We shall have data on medications very soon, because we have 17,000 patients to analyze. However, then remember that what I'm bringing is hypothesis generating, and we need to test it. And it's very easy to test it for immunotherapy as well as for monoclonals, because in omalizumab, there might be some signals.
Okay, Professor. Professor Tanti-Lipicorn, would you have a question for Professor Busquet?
Thank you very much, Professor Recto. Professor Busquet, so I think that's a great talk. Because of your next generation of the area guidelines very popular in this region, and the concept of the stepping up and the stepping down that you propose from your next generation area guideline seems like is a big change comparing to the area originally that you say that the stepping up and the stepping down after the 3 days or 7 days. Would you mind to elaborate more about this concept?
Well, this will be the big area meeting next year. It will be next generation guidelines based on big data in digitally enabled patient-centered care pathway. Because what we need what the patients are doing. And you know, it's fabulous. Well, we have new data, which are extraordinary. If you take all European countries, you have the same pattern of medication use in all countries. It is, during the pollen season, we have an increase in oral antihistamines and co-medication. So this is not in guidelines, it's again guidelines. This is not in physician prescription. So what we need to do, we need to go to next generation guidelines based on data and not based on the opinion of the opinion leaders.